Welcome. Good to see you. For those of you who don't know me, my name's Nikki. I'm the chair of the Research and Practice Network. And if you haven't been to one of these events before, the way it works is we just get a few local presenters to present their case, something that's of interest, either because it's a clinical reasoning bit of a dilemma and it was hard for that person to problem solve it, and they're either asking us to help them problem solve it, or they're sharing their own insights and learnings that they develop along the way, which will help us in the future if we're faced with a similar case. It might be a management dilemma. So again, we don't know what to do with this case. We've tried everything. We don't know how to fix it. I'm unsure. We can look to the brains trust again for more ideas. Or there's other formats so you can present an interesting article or something that is of interest for all of us to increase our collective knowledge of.
Excellent. What do you need?
Thank you to our sponsors who fund the food and alcohol for these events to go ahead so that we don't have to charge anything for them. And thanks to Regent Street for hosting us at short notice. For those who have never been to one of these events as well, we have a couple of times a year, we run a large multidisciplinary presentation where each of either a local presenter or a research expert comes and presents snippets of information of gaps in knowledge of conditions that we treat locally. So this one that's coming up is on lateral hip pain. So we've interviewed a bunch of local clinicians to find out what they do to treat lateral hip pain, and surprise, surprise, everyone does a whole bunch of different shit, and it's not necessarily evidence-based. And the orthopedic surgeon and the sports doctor and the physio and everybody's all treating them slightly differently. So these type of events are designed to try and bring everybody together to go, right, what does the research expert say about what we're doing and where the gap is between what the research says and what we're currently doing, and we're trying to increase the local knowledge and create some care pathways and things to improve the way that we treat these. So there'll be a QR code to register for that, and you should have all got emails about this event. So come along, it's free, and Angie is also staying the night and she's doing a workshop the next day. So any practical tips from that event, that like the session's too jam-packed with info to make it a practical session, but if you want to follow up and do a really good hands-on practical session, she's running on the next day at the uni at New Beds. So register for that if you're interested. So these events are a safe space, share, learn, stay wherever you want. Don't be judgmental of each other. If you have a question, raise it in a nice polite way. Don't shout each other down. We're particularly about ideas and thoughts, and give everyone a chance to speak. So I'll introduce our speakers. So we have Lucia, who has been physio for a long time, and Lucia is teaching at the university, and she's recently taken up practice here at Regent Street. And you're a titled musculoskeletal physio, and so Lucia's going to present a case on a shoulder issue. Beau is currently doing his Masters of Sports, and doing some research at the moment on hamstring and soccer, football. And he is exercise sports science trained as well as a physio, and has done a lot of work with elite football with Wellington at the Bins. Is that Wellington? Sorry. And then Josh, this specimen of a human over here, former physiotherapist, orthopedic trainee, set free trainee. He's up at the 100 at the moment on trauma, and sees a lot more of the people at the hospital than he does in his life. As kindly put some cases together for us as well. So Josh is presenting a case of a complex nervy thing that I won't give away the answer to. So I'll bring up Lucia to start this evening.
Cool, that's cool. So anyway, the title of my case is the supple frozen shoulder. A little bit of background before I get going. I guess it is a clinical reasoning case. You'll see as we go along, I don't think it's a difficult clinical reasoning, but the main points I wanted to get out of it came about from a conversation with Andrew, our local shoulder guru. Where's he gone?
He's gone
somewhere. That we were both seeing more of, I guess, what you call a mould up version of frozen shoulder, different to your textbook cases. It also came from my own personal experiences, which was the reason I saw Andrew after 10 months of shoulder pain that I was ignoring. And I finally realised when I looked in the mirror one day, it doesn't move quite as much as the other one. Maybe it's not a tendinopathy, maybe I just have a frozen shoulder. And I was just like, I didn't think it would be, I thought it would be worse than that. And we've both seen more of them. Also, you may be surprised, but I am in the prime age group for the frozen shoulder. I know it's hard to believe. And all of my friends had frozen shoulders, and they all actually are not really severe ones. So I guess this case I'm going to talk about, it's actually not me, it could be me, but the case I actually saw, and I picked it up really from the history. I had that suspicion. And at first, when I looked at her, I guess what I'm trying to say, it was easy to miss. And she'd actually already had physio elsewhere, and it had been missed, and she'd been treated as something else, and it was made, worse. So I guess that's kind of the whole point of this. I have an alternative title based on that little background story, and having lots of friends in that age group. This is my alternative title of Please Don't Also Dismiss the Middle-Aged Female with Shoulder Pain, because she has run out of absolute everything to give. When I put it out on my various WhatsApp groups, because I was meant to be somewhere else tonight, I said, I can't, I've got to give a talk on frozen shoulder. Should have seen the comments, and there was a lot of swearing. The doctor missed it, and this and big and that. So there's a lot of it happening. And the other thing, look, I know probably my friends, it's a particular group, it's they're reasonably well educated, they're professional. They're not sitting around at home, they're going to the gym and lifting, and they don't have time to have a frozen shoulder. So I guess again, you don't want to miss it, because they want to be doing pull-ups and they want to be doing overhead presses, because the word on the street is they want to be doing resistance exercise. That's the latest, it's finally the message has got through. So you're going to see a lot of pretty well 50-something-year-olds. So introduction, pretty straightforward because it was. So 53-year-old female that I saw, would have seen her in January. She had a 3-month history of increasing left shoulder pain. There was no obvious mechanism of injury. Didn't have really much in the way of relevant past or social history. She hadn't had any previous shoulder history. I'd seen her once, a couple of times before for episodic neck pain, otherwise quite well. No history of trauma. As I said, I guess the purpose of this talk is very basic, but a clinical reasoning dilemma. So, as is often the case, it was a bit vague when it had started, but she couldn't think of any mechanism as such. It had definitely got worse in the last several weeks, and there'd been a couple of things. She put it down to she'd had an increase in activity in the garden, which fitted in with your overload type of injury. But she had also in the last month seen another physio, and no disrespect, I actually said to her, I completely understand why this was missed, and honestly, I think it was because of my own experience that I picked it up. It only took me 10 months to realise that I had a frozen shoulder. So I think I was kind of in a good place to pick it up, because just from a history, it was easy to miss, and if you just had a quick look at her mobility, it would also be easy to miss. It was localised, there was nothing unusual, there was no neck pain, there was no referral, there was no neurological symptoms. She didn't have an inflammatory pattern, which I know is typically a textbook pattern for frozen shoulder. She didn't have pain at rest, it was just when she got to the end of range and it hurt, but then it settled down pretty quickly, so it wasn't irritable. She didn't have night pain, but it was starting to bug her at night with lying on it. And she was certainly having troubles with sort of end range movements, typically with females, getting your bra undone, that type of thing. So aggravating, arm overhead, lying on that shoulder, but otherwise she was sleeping well, she didn't have any morning stiffness, she was okay during the day, it was just hurting if she was using her arm. And as I said, that was the other thing that I guess I had to help me, is that she'd had, I think, just a 1 or 2 off physio where they diagnosed her as rotator cuff related pain and given a resistance band. And it wasn't heavy, but it was enough to really stir her up. And so to me, again, I was like, well, that obviously hasn't helped. We might need to have a bit more of a look at it. No previous shoulder pain, bit of neck pain. So again, we always need to rule out the neck, but that could have been relevant. But otherwise really healthy. She's actually on the slimmer side, certainly wasn't overweight, no medications, nothing else in terms of common risk factors with frozen shoulder. Perimenopausal, and we'll have a bit of a talk about common risk factors or associations with this as we go along. Social history, no yellow flags, lives at home with adult children, works part-time as a teacher's aide. She walks regularly, healthy diet. She used to go to the gym when Kerrs was open, but she hasn't done it for a while. She was wanting to get back into some resistance exercise. So again, there was really no clear history of overload, other than she thought had put it down to working in the garden. Could do everything, just got pain when she sort of got into these. She said, oh, it really hurts when I go overhead. Certainly when she was doing heavier activity with the gardening. I think she had, you know, hedging, it was that type of thing. It had really stirred her up. And certainly the bit of resistance exercise had stirred her up as well. So, other than the fact that I've titled it the subtle frozen shoulder, what do you think, if you just look at the history findings, what are the history findings that could point to it being rotator cuff related pain? So put it out to the audience. Is there anything in the history that indicates it could be that? If you ignore the fact that I gave you the title.
You said load related stuff like the spiking load.
Could have been, yeah. So there was that gardening, yeah. So, you know, certainly that fitted in with you know, tendinopathy type thing.
Sleeping on it.
Yeah, sleeping on it. Yeah, it's intermittent. That acts like rotator cuff pain. Is there anything that might have, you know, if you're thinking about another option, sorry, the other obvious option of adhesive capsulitis, frozen shoulder, is there anything in the history that really points to that? What's it, sorry?
Demographic.
Yeah. Yeah.
It's just like insidiously and then it's getting a bit worse.
Yeah.
For no real reason.
Yeah, that, yeah, I had it in the back of my head from early on, even though she didn't have that night pain, that line on the shoulder, and demographic. I looked into the research, and funnily enough, they don't do research on middle-aged women or women, full stop. I mean, there's research that's a population that it seems to be much more common in that age group, 40 to 60-year-old, more common in females. I couldn't find anything about any clear link to hormonal, but I guess that's the age group when that stuff's going on. I don't know if anyone's got any other knowledge about that. Certainly anecdotally, I'm seeing it because a lot of my friends are that age. So yeah, really there wasn't anything clear from just the history alone. But you needed to keep both of those options in mind. Differential diagnosis, always need to clear the neck. I had seen, I didn't put the details, it was quite some years ago, she actually did have some nerve impingement in her neck. It had settled down quite quickly. I didn't have her notes, but I actually think it was on the other side, but we knew we needed to clear that. I guess possibly something intra-articular OA label. There wasn't a, you know, I think a clear history for that, maybe AC joint. I was just trying to think of anything else it could be.
I guess you could debate, Lucia, that the demographic points to tendinopathy though too, because of the drop in estrogen.
Exactly. Yeah. Yeah. And that's you know, we know with the change in estrogen, you do get changes in the connective tissues, so your collagen. And that's where the thought is that that age group of women particularly are more at risk of tendinopathy overload, but also in terms of the background of frozen shoulder, where the thought is there can be a trigger that sets off the process. Maybe there's something there as well, but you're right, there could still be that demographic. So I guess my point is, from the history, you really couldn't pick it. I guess so again, the fact she'd had some physio and what they'd tried had made it worse, that also gave me a starting point. Is it didn't seem to be enough exercise that if it was a tendinopathy that it should have made it that worse, and it did. It quite stirred it up for a few days. So physical exam, neck was fine. Okay. I started with just having a half-assed look at her shoulder range of movement. And if you just looked at her, she could get her arms above the head, you know, abduction, flexion. And by her side, didn't look too bad. You know, if you just had a look at that, hand behind the back was definitely more restricted and was ouchy. Isometric was fine. Okay, so if you're thinking about, okay, if it was a tendinopathy rotator cuff thing, I did test it with handheld dynamometer, but she really was fine. Her strength was good. Didn't have sort of any specific tenderness on palpation. She was positive on her supposed some of her impingement tests, but I think you'd know that you'd expect that to be uncomfortable if she did have capsulitis as well. So just, you know, those tests aren't terribly good diagnostically on their own. I think they're better to rule out. You know, I had a look at some basic slap tests just to rule it out, like bicep, long head of biceps, and she was fine. So if you just, I guess what I want you to take away from this is if you just did that, you might still think, well, there's nothing really there. And that was where the conversation with Andrew came about, was the need to really measure these properly. Because if you just looked at that, it still might be a bit vague as to what might be going on. Whereas when we properly measured her passively, I did it in supine and I stabilised her scapula, that's where you could see the difference in her range. And what do you, it's not too easy a question. Why do you think it might not have looked too bad in standing? Just if if I'm wanting to get a sense of a glenohumeral rotation, what was probably compensating? Scapula. Yeah. It didn't look too bad, just eyeballing it. Whereas when you stabilised her scapula, and she had the range to come up to 90, that's where you could really see quite a difference, particularly with external rotation. So yeah, that I think was the main thing I wanted you guys to take from this, is the importance of really measuring well, because whether it's the earlier stages of frozen shoulder or just a milder version, and again, it wasn't that she was at the early stages, she didn't get any worse. With some simple management, she calmed down and then she was able to get into stretches, and she's nearly 100% now, 4 months later. So I guess that's the other argument we have, is maybe you caught her at the early stage, but I don't think we had. It didn't actually get any worse than this. But if she kept going on with resistance exercise, it probably would have stirred her up and probably wouldn't have helped. So she didn't have a big loss into flexion, but she had quite a significant loss, particularly into external rotation. And it was really uncomfortable at the end of range. She'd already had some x-rays and ultrasound. I didn't ask for those, and surprisingly, they were fine, but showed up some minor tendinopathy, bursitis. So I explained to her that that's pretty common in her age. So in terms of what I had to do some clinical reasoning, I felt there was no reason that we're thinking that it was cervicogenic, an AC joint. I didn't mind on there, but I cleared that. I guess you can't really clinically rule out OA. Oh no, she had the x-ray, hadn't she? Sorry, got that point. So wasn't thinking she had OA or anything else in particular. And the main difference between was it rotator cuff related pain versus frozen shoulder? Yes, she was positive on an impingement test, but they're going to be provocative anyway in a frozen shoulder, because she's not going to like that in range rotation. But the factor isometric testing was fine, yet she had quite a significant loss of passive range of movement in I guess 3 directions. And the fact that she was made worse with doing resistance exercise at that point. So that was where I thought it was most likely adhesive capsulitis. Obviously the title of my little talk. But, and as I said, management, it was really nothing fancy. Education, I think, is really important, because some people get quite panicky about the name frozen shoulder. Giving her some insight that it can take quite some months to fully resolve. I organised for her early on a letter to go back to a GP to talk about getting an injection if she needed it, because I didn't know at that stage whether she was likely to get worse or better. I didn't know when I first saw her where she was on that spectrum. And I think most of you know, with frozen shoulder, it often builds up from a gradual pain to more pain, and then often that reaches a peak, and at the same time your restrictions coming in, and then it turns into more of a stiffness problem. She didn't really reach that really highly irritable point that you often read about in textbooks, and I'm certainly seeing more of those. I just got her to stop doing a resistance program she was doing, CCO to do gardening work. So calmed it down, really just calmed it down, and got her into capsule stretches. And I think I saw her initially 3 or 4 weeks after that first visit, and just with that, she was a lot better. She didn't worry about getting a cortisone injection. She didn't feel she needed it. And I think I've seen her twice since then. I saw her only a week or 2 ago, and she's got nearly full range of movement, and we've just started to bring in some resistance again. So I guess audience participation, I'm interested. I assume that you all see frozen shoulder of some degree. I was just interested, are you seeing more your classic cases, or are you seeing some older ones as well? Is anyone else seen someone like that? It was. I know you guys will. Yeah, you guys
I
will.
wonder whether catching them early when they've had not much advice and not much treatment. You often see them and they've tried everything, and by then you think, "Fuck, I wonder how much all these extra stretching and manual therapy and hanging off the doorway and all these exercises in that early stage is actually just ramped them up even more."
And that was
they're like noticing it sore, they hanging out and stretching it even more. Anyway.
And that was, I was conscious on Thursdays of not really knowing where she was on the trajectory of your typical frozen shoulder. I think I did follow her up in that first sort of 2 or 3 weeks just to see how she'd gone in case she did get worse. But yeah, it sounds like the point that she'd done the gardening and she'd been given the resistance band, she probably for her that was in her peak time, which is what had stirred it up. But she hadn't been given stretches of any kind. But again, they're things I know we've talked about here before, is if they're in that quite inflammatory phase, you don't want to go overboard with your stretches and your modes because it can actually prolong that phase and certainly irritate them. So you have to pick your time to bring that in. Yeah, so certainly so now again with your mold frozen shoulder cases, what are the background that you think might have put them more at risk? Are they mostly that middle-aged female group? You've seen a lot of those. I've seen lots of frozen shoulders. I don't see many blokes, and I know the literature says that there's still a reasonable number. I don't know. Are you guys seeing lots of blokes?
Oh, I'd say a few.
Yeah,
But not idiopathic as much. Not
I see them after trauma. Like I've seen a few after falls.
Yeah.
Or
Yeah,
a diabetic, like unhealthy.
Yes.
I think
You know.
my personal feeling is that we see more and more of them in, whilst that's the classic demographic. I had a young girl who 19 years elite level surf athlete who ultimately saw everybody under the sun, not men, but lots of other people. And ultimately they end up saying it's a frozen shoulder. So I sent her to Sydney and saw Ross and what have you.
Yeah.
And they went, this is a frozen shoulder.
Yeah.
19-year-old.
19. Wow. So that's
19-year-old
unusual.
just
Yeah.
no, just and so just bizarre.
They can affect all the age.
And so I think it is important. So there's two things. I think one thing is your manual handling to pick up these subtle ones is really crucial because if you're just doing this, so I think we have we've worked hard at trying to be more measure what. So we don't use it, although you've used the picture of goniometer there.
I just read that.
We don't use the goniometer, we use the implanometer and we lock up the shoulder and we feel what's happening with, so we do that pretty well.
And it feels,
So anyway, so I think it's really important, the way that you do the manual handling you won't pick them up unless you're doing that well. I think it's still worthwhile being mindful of that it can happen. If you've got somebody who has clearly it's restricted range, then don't dismiss it just because they're not involved in that environment. But I think the conversation that that we've just had with Ben earlier was, so Ben's just talking about the just going a little bit more gently on them when they're in that acute phase, which I think that's my mindset when you have a look at these capsules, and you will have seen them when they're unhappy, when you've got an unhappy frozen shoulder, they look horrendous. They look horrible. It's all red, all red and inflamed. So
you don't want to be going.
So this debate about the hydrolytation, this conversation Ben and I just having earlier tonight, is that the cortisone is the thing that helps calm it down. But all these ideas that I'm saying to Keith, when you've got a frozen shoulder, hydrolytation to me just doesn't make sense in terms of the point that will give is most likely going to be the place of least resistance. So it doesn't make much sense to me anyway. So I think the thing that works is the cortisone to help calm them down. And what you've said in terms of just let's go, and I think it really makes sense to me. Don't go when you're really angry. When I was 30 years ago, when I was first, we actually, used to what I said, get them to bite on the stick and just go as hard as you possibly can. And it's just disaster. No. So I think there's identifying these subtle ones, and we've all had them where we've gone, I think that's a cuff, and they've come back and we've gone, I said it was a cuff. This ain't a cuff. This has progressed a little bit now, and this is what it is. But I do think that there's memory. So I think just changing our tack a little bit is important. There's not a lot of, I don't think there's a lot in the literature to support that approach, but the more I see it, it's
Yeah, and I think that the literature is not nuanced enough. Just it's tricky because if you're ever going to do a study, is to try whenever you try and we like you mentioned about different phases, people go on this journey with their frozen shoulder. And trying to recruit them, you can't homogenize everyone on phase one, and I want to start treating the people. You just capture them when they turn up, then they're frustrated to the nth degree, and there's like some people been there for 10 months, other people have been there for a week. It's such an homogenous group, so you're really left to, I know the experience of people who are thinking about it, who are seeing a lot, who it's starting to piece together for them, but it's really hard to do a study to recruit patients enough, because then if you do get together, you can't really draw any sense because there've been enough people that just got better on their own.
Yeah.
And so then it just clouds the picture, which is makes it really tricky to interpret. And I think the big point of which is I'm really glad you brought it up, because frozen shoulder is not just I'm stuck, it's pain, and no, I'm not shooting. It's like it is a big spectrum of presentation from very mild to horrendously severe, and how you approach it, there is some nuance to it. And not everyone gets treated the same. And it gets the less obvious it is, it's probably the easier it is to treat, and the more obvious it is, the harder it is to treat. So I think there's been art to it. You should just be aware of.
Yeah, and I think when you should be fairly aware of all the different risk factors, and there's a whole range of them. Yeah, so you've got the sort of most common in that 40 to 60-year-old. Within that, it's more common females. Again, what other not the people that deal with frozen shoulders all the time, what other risk factors have we got that seem to be associated with it? Yeah, diabetes. Yeah.
Previous frozen shoulders. That
On the other side,
yeah,
yeah.
actually talked just before in terms of that's on the other side. Has anyone ever seen it happen to the same side again?
Yes.
Oh, there you go. Okay, so no, yeah. Okay,
Yeah.
able to see
Which I
that.
thought that you could,
Yeah.
but unfortunately it doesn't. I
Yeah.
don't know whether it's actually a recurrence or again, like it's gone away and come back, or it was actually incompletely treated and has re-fled. Yeah. So I like to use the analogy of that, particularly in the first phase, you've got this fire that you're trying to manage, and we're trying to quieten it down. We're trying to quieten it down with steroid and activity modification, and ideally we like to go out. Once it's out, you can be a bit more comfortable. You're not going to aggravate it quite easily with your stretches and physiotherapy. But a lot of people don't plug in range in any way, so you don't even really know if it's really out. I think that's all right. And everyone wants to be fine. They want to get back to their activity. It's been going on for ages. So I think some people who get that again probably weren't actually out and they've been smouldering quite some time, and it just hasn't gone, and they didn't actually have another injections, and they're uncomfortable and they cost money and it's inconvenient, whatever. They actually never really put it out. They just tolerated it smouldering quite some time, and they aggravated it again, and it just took off.
Yeah.
That's probably a worry.
So do you think, like, if someone gets to the stage where it's not affecting their day-to-day life very much, but they're still limited, do you think it's still worth injection therapy or anything, or do you think you'd leave them?
Personally, yes, because I don't back to them to plenty. So I personally want them to put the fire out, and I think it's normal. I don't get you guys, and you guys can play around with them, and they'll get better on their own. But when they're grumbling, they're just they're on the verge of flaring up again at any point in time. Might be, I just went to wash the car, or I hung the washing up on the line, and we did the sheets today. I've hung up the washing all the time, but the sheets was too much. Then on my shoulder, and then back again. I see a lot of that, and people aren't really patient with it. It does drag on. So I like to just I'm getting more aggressive trying to put them out. And when I say put it out, it's to get you out of the painful phase. I don't care what the range is, but get rid of the pain, and then you can go hell for leather. But what incidence of people get the other side affected? How high?
Is it like 15%?
50%. Within 2 years, you'll get it on the other side.
they do much better on the other side though, because they go on.
Well, I remember that's why I told you
Yeah,
that you will
and
notice pain before anybody else will notice. Like before anyone can do an MRI, that can tell you, before anyone that will probably pick up the nuance of your examination, you will never forget the pain. When the pain comes on, you remember it, and you'll remember that I told you that, you'll go and get the injection, just put it out, and so you won't have to go through the bullshit.
Well, it was never, yeah, I think that's my, I've got many stories. I can do many talks on the stupid things that I've done. But honestly, I just thought it would be worse than what it was because I didn't need an injection, and I think I kind of self-manipulated myself at the gym and was like, oh, that feels better. And that was the point I finally looked in the mirror. I was like, hang on, there's some loss of range there. But anyway, yeah, so look, I think, do you remember what's on the next slide? Let's see. Put down. Yeah, so take home messages. It's nothing fancy, but we just, after talking to Andrew and having my own experience, seeing lots of other people my age go through it, we thought it was worth just pointing out. You always take a good history, you know that, I don't need to tell you that, but particularly question closely, not just where the pain is, what sort of things aggravate it, the 24-hour pattern. And I know that my case and others aren't strongly inflammatory, but looking, is there an inflammatory pattern? Is there a history of overload that can help? But really that on its own doesn't tell you whether it's more likely to be rotator cuff related or frozen shoulder, because often there's aspects of both. But do a really good range of movement measurement. That was really the main point of it, is that it's easy to miss, even if you do measure. But if you do it in standing and you're not blocking the scapula, it's easy to compensate with your rotation. And I think that was the main point. And it'll feel different as well, you know, if you're thinking about end range. Yeah, and you know, very different to what you typically find with the tendinopathy, which you know, often their passive range is not too bad. Again, exactly what Ben said, there's a really wide range of frozen shoulder presentations, and a lot that are much milder than what you think they might be. And it could be that you're catching them at the beginning. So I guess again, the obvious is someone's not getting better, relook at them. Even if the first time you saw them, it looked like they had fine range. Maybe they were just in their pain stage, because frozen shoulder starts with pain. It doesn't start with the loss of range, that comes on later. So maybe you need to relook at it. And be nice to the middle-aged female with shoulder pain, because she's got lots of shit going on at the moment. And those happy hormones have left the building. Let's be honest. So yeah, be nice. And don't dismiss her. Because she's trying to do other stuff. I think that was all. I had a few resources if you want to have a little bit more of a look up about it. But that was it. Pretty straightforward. Take home message. Any questions?
Yeah.
Yeah.
All right, so I'm gonna do my case on an athletic groin pain. I've got a little thing to scan to try and get everyone's opinion on their diagnosis, so get ready for that as well. Rather than I wasn't so nice as Lucia to give it away at the start. So I'll try and be quick. So I've got a bit of information. This one kicks on for a year, so we'll go through it. So as Nikki sort of mentioned, I was in charge of the Wellington Phoenix Academy for last year. So I had an academy goalkeeper come in. He reported this acute sort of on chronic groin and abdominal pain that had started in October 2023. It was an insidious onset at the start. It got better over the off season. Their off seasons between December and January. But when they returned in February, his pain returned sort of insidiously after about 2 weeks. And the patient sort of thought it was just that return to sort of long kicking and goal kicks. Then he sort of self-rested and took care of himself between sort of February and April. And then he had this acute pain when having to do extra conditioning. I don't know why they would prescribe extra conditioning to a goalkeeper, but here we go. And then he sort of felt this like acute moment come through his sort of groin and the abdominal area. He self-rested and it got better, but then by May he had this acute pain reoccur and this sort of more stomach stabbing pain following sort of a large twisting goal kick when you're trying to kick it further than normal. And that was sort of the time that I'd seen him. And when I'd first sort of seen him in May, he's continuing to train, but just sort of self-modified, which is what a lot of sort of academy kids do if you ever get a chance to work in an academy. So on his sort of initial assessment, this was sort of his subjective. So his worst pain was 8 out of 10, but settled immediately if he stopped doing what he was doing. However, if he pushed through that sort of 8 out of 10 and continued with training, his sort of pain lingered around for a few hours. His main aggravating factors were sprinting, taking long goal kicks, coughing, sneezing, and sort of any abdominal work. It was only really better if he stopped doing that or rested. Didn't recall any morning pain. It was more mechanically aggravated, no night pain. It was pretty healthy, no general health or medical or sort of neurological concerns. He sort of didn't report any sort of hernia bulge, which is sort of what I thought would be the first case coming up with one of those incidents. Socially lived with his parents. New Zealanders do a lot of their last schooling year online, which enables them to go into either work or sport. So he was part of the academy, trained 4 times a week and played 1. And then sort of the only yellow flags that I had around him, that was not maybe coming from him, but it was more the academy space, is the coaches sort of reported that he'd come back heavy from the off season. And he was also fighting for the #1 spot in the academy. And as a goalkeeper in soccer, if you've seen them, if they're not #1, they're out because they don't play. So #1's really, really important. And I just had that in the back of my mind that like heavy is instantly for me is if he's fighting for #1 and a coach says you're heavy, you're not going to be #1. Like it's just not going to happen. So that's something back in my mind that I had. Apologies for how poor this came up, but this is sort of my quick objective findings. Had a little bit of pain with lumbar extension and left lateral flexion. It was his right side predominantly. He had pain coming into flexion and internal rotation of his right hip. Whereas on his left side, it was similar. It was a little bit restricted, but that was more that sort of anterior pinch pain that most people get in that sort of theta position. His pain was replicated with internal rotation of his right side, and he was replicated as well with sort of like an adduction and some long levered stuff in that area. His range of motion through his adduction was kind of fine, but he had some awareness. And then his adduction power, like I said, was a bit limited. When I had a look at sort of some more specialized tests, on a Thomas test, he was able to sort of get into a position with goalkeepers. I wind them all the way up as much as I can because that's where they get a lot of their power to get their long kicking. So when I wound him up, he did get like a crossover pain and replicated from the other side. If I was doing his left side winded up, he'd get some right-sided pain. And then on the right side, putting him into that end position, he sort of got pain in there, and then activated with the power, he got pain as well. Painful to just do a squeeze of my fist. Pain, unable to do a sit-up. He was tender everywhere. So he was tender over his adductors, he was tender over his pubic bone, he was tender over his inguinal sort of line and region, and he was tender over his hip flexors. So he was very, very aggravated, and he was sort of at that 8 out of 10. If he coughed, he had pain. If he ate active straight leg raise, he had pain. And apologies, I don't know how to keep that up and keep this up, but have a scan. Let me know what you got over that. I will preface this. I only get, so in the academy, I only got 15 minutes to do a full treatment assessment look at. And as he wasn't #1, he didn't get much of my time at all. So like he'd be lucky to get me once a fortnight and for 15 minutes. So it is quite a direct one to be having. So apologies if there's things that I've missed on my objective and subjective, but so I guess whilst you're doing that, I guess what we've got on here is we've got some inguinal related pain, pubic symphysis injury, pubic symphysitis, an adductor related injury, groin pain. Not wrong. Someone's put in all of the Doha categories, some with Magnus, I don't think I'm missing a stressy, and a labral tear. So yeah, there's a lot going on. And to be fair, that's exactly what went through my head straight away. So I was like, fine, I got 15 minutes for this kid. If for whoever hasn't seen a Doha, there it is. So these are all the different ones. There's a picture of it. And if I put that into my table, apologies for how crap it looks, but you've got something for everything, which is, it just wasn't really helpful at all. So I've got some sort of other with some back stuff. I've got a hip related stuff potentially. I've got some pubic related stuff. I've got some inguinal related stuff, some hip flexor, and some adductor. So I was like, okay, cool. So being in professional sport, I was lucky enough to be able to sort of refer straight to a sports doc. And in New Zealand, it's actually really cool. Their Medicare is much easier. The physios can refer straight to sports doc and orthos. But in order to get any imaging at all, except for an X-ray, they have to go through an ortho or a sports doc. They can't go through a GP. So imaging over there is quite challenging to get to, but getting them into people is actually a little bit easier. In saying that, Wellington has one sports doctor in the whole of the centre. Like, it's the capital city of New Zealand, and there's one. He's got a 2.5-year wait list. So
Just right next to my referral.
yeah, this guy's just pumping MRIs. So yeah, I mean, being with the Phoenix. Yeah. So anyway, this was just initially my thoughts was, okay, let's get an ultrasound on his inguinal. Oh, I apologize. I could order an ultrasound and X-ray. So I was like, let's get an ultrasound on his inguinal region just to see what's going on there. An MRI on sort of his groin and hips, check for all those things. An X-ray just to see if he's got like some sort of FAI going on and maybe just got a grumpy hip. And then initially, let's just do some handling work until his diagnosis settles down or appropriately tolerates his training load. So Joe's working in professional football. Sports doc had a wait time of 6 weeks, which really isn't too bad, given what I just said. But within the following week after seeing him, he'd done 2 days of just some handling work. The number one goalkeeper for the first team gets injured. The under-20s, that was currently the number one in the academy, goes off to the under-20s World Cup. So the patient gets invited to first team training and assured game time. So he's like, heck yeah, I've been dealing with this for 6 months. I'll screw it and I'll just keep going. So rather train and play. He did really, really well. He's just tolerating his pain. And 4 weeks post his sort of initial that I seen him, he jumps up for a catch and rolls his ankle, can't wait there. I sent him for an X-ray and he has an osteochondral injury. So then his original sports doc review got changed to stamping his ankle because he needs an MRI and he's the only person that can do it. But then he rebooked him for a week later, which we were lucky. So had a little bit going on. I guess why I put this slide in here is because this originally got his original pain started in October 2023, and I seen him in May, 6-week wait time, and then it got added more and more. So time's just getting ticking here. The sports doc ends up seeing him for his groin and ankle, but he referred him for the ultrasound. I didn't, because I thought if he's referring for it all, may as well just do all the imaging. And for an ultrasound of his inguinal region, and also to a general surgeon, his reasoning being it's been 6 months and we've got an 18-year-old kid. Something weird's going on, so let's get that checked out. So the ultrasound came back with no inguinal hernia identified, but an MRI may be benefit as there's partial stripping of the rectus abdominis, and then some particular angriness around pubic symphysis. So the surgeon then seen that, referred him for an MRI, and then he's got osteitis pumice, so this is a comment, with bilateral right and left adductor origin tears, and nothing really wrong with his abdominis or hernia. And the surgeon placed him on some heavy anti-inflammatories and told him that the pain that he was getting was due to like the insertional adductor. So following up, the patient was still with the first team as he technically got injured on the first team training. So for insurance reasons, he got rehabbed with the first team for his ankle, but they were doing his groin and stuff sorted at the same time. So when I had seen him, he got dropped because he didn't get picked. So that September's around the start of the A-League time. So he got dropped back down to the academy with me. He reported, and I sort of just caught up with him in the halls. He reported feeling a lot better for about 2 weeks after he's seen the general surgeon start his anti-inflammatories. And he said that he'd just been working hard. He got dropped, so he's in the gym. He's also got told that his heaviness is affecting him. It's probably the reason that he didn't get picked. So this poor bloke's trying to lose weight with an osteochondral deficit in his ankle. So he's just really hitting the gym very, very hard as much as he possibly can. What I found interesting in the hallway, he said, but when I ran out of anti-inflammatories about 2 days later, I couldn't walk. Like his groin pain had just got super angry. He got pain with sleep, pain on waking. It was sore. And I just thought, that's really weird. But he went back to the GP in that time, got some more pain meds. And the GP was like, yeah, just keep going with the ankle rehab and, just add some groin stuff in there. The physios deal with this adductor origin stuff all the time. But when he was sitting in front of me, he was just deflated. It was a shell of himself. He couldn't sit comfortably. He couldn't walk comfortably. He sort of had pain to get in and out of the chair and squat. So I just thought, this isn't really right. What's going on here? So I had a look at his MRI. If I click again, I don't want to be waiting. Cool. So now I will admit I'm not the best person to read MRIs. And I screen recorded it, so, but like that to me, apologies for how crappy it is, but that to me, and like here in the actual bone, that's not good. There's signal there compared to like up through here, and like yes, you've got some where it comes off the bone and through the origin itself, but in my opinion, I thought there's some signal through both the superior and inferior pubic rami there. I was like, oh, like what's going on there? And you can see it pretty much clear as day on that particular one there. So I rang the sports doc and was like, what's going on with this one? And the sports doc was like, yeah, I believe that's a grade 3 stressy. Can't see a fracture line. But in the same event, he also said we don't need any further imaging because, you know, what's a fracture line going to tell us? Not going to change much of our treatment or diagnosis here. So he was mainly saying that like this part, and that was the biggest thing that I came through. I've got a stress fracture, and these GPs and surgeons are just loading him up with anti-inflammatories to treat his enthesopathy, which is great. But are we just absolutely cooking it stressy? Which, you know, he's come back and he's out 9 out of 10 pain, can't see it. I would say he definitely was. So the sports doc agreed to wean from the NSAIDs immediately in favour of the stress reaction over the So I hadn't seen the stressy of the pubis and for the anterior pelvis before. I stole this off you and your website. So I thought it was really good. But I had a look at a bit of the research and just like how frequent are these? So stress fracture and musculoskeletal injuries are 4% of normally what the cause of pain is. And of that 4%, 1.5% are pelvis. So they're pretty rare. I'm surprised someone got it on there, so who did that do really well. But I just thought I have no idea what this is. I had a look at the evidence. Mainly they were case reports and studies about what people could do with these. And I was thinking, okay, well, he's had it for a year. Like he might be a surgery candidate, but what surgery? I've got no idea. And from every report I'd seen, they didn't really have as much effect as conservative management, if conservative management was done really, really well. So I just went back to the basics and opened up a Brooker and Kahn book and was like, okay, what can I do with this and how can I get this information across to a 17 or such 18-year-old? The biggest thing for him was really high education, made sure all activities, every single one was pain-free. He had a pain diary to make sure that he could monitor his pain, and so that if he did have any pain the next day, we could look back and go, okay, it might have been because of X, Y, or Z. And then obviously limited his medication. I said if he needed to take sleep or whatever, you know, take it as he needed, but like really try and wean off his meds as much as possible. So back to basic with the stressy and just sort of seeing how he went. And so I got deported home. So over the next sort of, I seen him 3 more times. So over a 6-week period, this is sort of his results. So I'll let you read through that as much as you want. The big ones that I sort of see at this, like if I had a look at just his subjective prom, like he was 12 at that time that I reviewed the MRI, which if I've never seen a Hagos that low. I don't know if anyone else has seen one that low. That's not good. Anything under 25 is not good. So to be half of that is pretty rubbish. And within 2 weeks, he was still poor. So like that's pretty crap. I think on the Hagos for minimal clinical importance, it's 15. It's about 11 or 15 or something like that. So he not only had he gone up a sort of bracket of being very poor to poor, which is more sort of just a random line in the sand. They're just every quartile. He'd actually gone up a fair amount. And then what I thought was really interesting with this is I only gave him education for the first 2 weeks. I said, just like, let's be really smart about this. And he came back feeling super strong. He was like, I'm way stronger than what I'd done. And hadn't done any gym. The poor bugger, we gave him some swimming to do. I just got him a board between his legs, get some upper body stuff. And then he had a skin reaction. Because he couldn't sit on a bike because that hurt. So, you know, anyway, I was starting to lose my patience with the Kiwis by that time. I didn't do a spit for the first time, and this is something that I just do in professional sport is like get their adductor for the first lot of pain. There's not much evidence that supports it. They normally support whether it's a pain-free squeeze or not. With a lot of Edna King stuff, is just like as soon as it's pain-free, we're good. But I like getting a bit of a number because it sort of tells me if these two are linking, he's telling me it's good and objectively it's feeling a little bit better. So that's my justification. And then, I mean, the typical reloading, he went from double leg bodyweight exercises to single leg bodyweight exercises as long as they were pain free. After 4 weeks, we reincorporated the S&C and started some more like standing lateral movement stuff for his goalkeeper work. And after 6 weeks, he was allowed to add some flat diving. But what I found extremely interesting and a large amount of my education had to revolve around was this. Like, his frustrators started to build last 6 weeks, but this bloke couldn't walk for a year. It's like, mate, like, we've gotten this far in 6 weeks, let's give it a couple more weeks. By this time, we're looking at probably about November. So he's had it for over a year. And as I said previously, he's the off season is December, January anyway for them. So there was no reason to push him back any faster than what we needed to be. Yeah, so I guess like my take home message here is it's really important to have the correct diagnosis. It's something that I got obliterated on my prac for my masters. Is like I like to treat a bit of everything and like to get caught by red herrings. And so it's important to really just treat sort of, you know, a main thing at least at a time. And when I was doing my master's prac, we did it online, so I was overseas. I sort of asked the specialized physio, I was like, okay, well, how could I make that better the next time? Because as I said from my objective, he sort of lit up like a Christmas tree. And one of the biggest things, and maybe for the young guys in the room, is like take a VAS for every single thing. Like, okay, it's sore, but how sore? Because he's reporting 8 out of 10. If I touch his inguinal region and he's saying, yeah, it's sore, but it's a 4, but I touch his pubic bone and that's the 8, well, maybe I'm a little bit more directed with what I can ask for, especially not being in the professional sport anymore. Then obviously check over the imaging. When you've got an umbrella term such as osteitis pubis, which is what it was reported as, you know, you could be looking at an endoscopy or you could be looking at a pubic stressy, and both of them are treated completely different. So really look at it and get it checked. And then for me, I was actually so surprised how well he did with like nothing. Like, I mean, nothing. Education really, really was key. He did well, and mainly just because of the fact that, I mean, I kind of put the fear of thought in him a little bit, but like I didn't have to do much, and he felt a lot better just by having some good education, which I'm sure to all the people that see stress is a big factor.
Okay. Oh, yeah. Do you think this was just unrecognised all along, and because he wasn't medicated, he never really fled it up too bad? Get him on the NSAIDs for a while, and then he goes too hard, and that's what setting up maybe worse.
Yeah, just this recurrent cycle. Yeah. Yeah. And also being the second goalkeeper, you're the guy that they come in when the first goalkeeper doesn't eat. So his load is just like up, down, like it just spikes all over the place. So once he became first goalkeeper, it actually was a little bit easier to recognise because like his load, you know. Yeah.
I have a question.
Yeah.
We're still on question.
Yeah.
Can we finish presenting?
Yep.
I have a question.
Yeah.
When I did the HIP FAI talk, and I learned all about the Doha Agreement and the whole, you know, they interviewed 23 specialists and asked them, they showed them the same MRI, gave them the same clinical picture and asked them to diagnose it. And there was like 22 different diagnoses that came up, not too dissimilar to this. What were the key features from the history and the physical exam that made it a bone stress, pelvic bone stress, as opposed to a non-specific, like pubic related groin pain case?
Well,
Like what made us hone in on, because you know how they say osteitis pubis is like one of those non-specific diagnoses. Tim, you can probably jump in at some point. I can see you like getting itchy over there. You know how that, you know, there's a movement away from these specific diagnoses because of the Doha Agreement. Everyone's, you know, pubic athletica, pubalgia, and all, they're coming up with all these fucking weird diagnoses that no one can agree on what it means. And so they've moved away from the specific and made it very non-specific and gone, right, let's just call it more pubic related.
But not used.
Yeah.
The reality is, I mean, this is the big case of, I did a study a couple of years ago, they looked at specialists that who uses Doha.
No one's using it.
And they said, yeah, 70% of specialists that don't use it, probably they're in France.
But no one agrees.
They're referring with osteitis.
I think the thing that I found interesting about the Doha is then it tells me it's pubic. So what's the difference between calling pubic and osteitis?
The reality is, I mean, you're talking multiple, most of them do multiple, it's just that region. And I think to be fair, personally, from my perspective, I don't feel a diagnosis is that important. Except in this case, when we're about diagnosis, you do. But in terms of what you do about it, it's individual. What do you
But
find?
isn't the image, it's not the image, it's not the image that
Not just
diagnoses
the
it.
image, it's the image
It's
you're
the-
matching up between.
That's what I'm getting at. So what are the key features that made you go, okay, this is not an asymptomatic lit up pubic bone that most fucking soccer players have. This is a stress reaction.
Yeah,
What are
I
the
think,
features?
I think like the thing for me and a lot of the time in like professional sport guys is that we have, well, I have a bit of a rule of thumb that like if it doesn't warm up, then I'm a little bit like, how are we going with this? Because for me, a lot of the grumbly adductors and like from working with Neil a lot, he's saying like, oh, they'll be able to get through training, they'll be able to push through it. John's push through it, all this sort of stuff.
Yeah.
Some of them they go through and they just like, nah, it's just sore. And if it gets worse with load, respectively, and then he just run 10 sprints in a row. For me, it's something more than attendance at play here.
And he was having night symptoms and stuff as well, wasn't he?
By the time that second review came around, and only when he weaned off his anti-inflammatories, and I think that for me too took a big one because like I mean, anti-inflammatories for me don't work that well. Like if he was taking that, it was something unordinary. So yeah, that's why I have them.
Real sort of touch, right? Both isolated bony tenderness with plausible radiological findings is concerning.
Yeah, well, that's it.
It's sort of because they're two of the same intention.
The
And
That's the thing.
radiologically, most
doctors-
sportsmen, they're setting up the season will have some kind of similar there, so you've got to match up.
But,
It's got
but are they not all tend to touch? Like the ones that the asymptomatic, not the asymptomatic soccer players that your MRI and 78% of them have the lit up pubis and have osteitis pubis on the image. Like you poke their pubis and they're sore, but they're not getting pain. It's just tender. So is that then osteitis pubis or is it a bony stress reaction or like, where do you delineate between?
It's usually low across the region. And moving away from when you categorization, you can't, you look at that, I mean, my first thought was about at least three to four animals in Doha, if you try to diagnose it.
That's right.
So it's just load across the region. It's called with like born pubes and most of the dog doesn't on the work, it's coming out. And it usually comes down to those accounts that they're loading up. So, but valid point because I think there's a really great area in terms of are they going to be sort to that? Yeah, but certain allergy groups, if you're touching that a bit sore, you touch somewhere else there more, then maybe there's touching the center, jump through the roof. Like you're saying before, the VAs, that's a bit relevant. You touch them there, they jump through the roof, the other spots aren't too bad.
Yeah.
That might be more. If they're touching there, it's over here that jump through the roof, maybe more, again, tendon and pieces rather than bone stress. But, expect that at that time of the season, now, we're sort of back in the season, because we saw everything.
Like we would do, at the Jets we would screen most guys on a weekly basis, and normally a pubic bone touch was just there because they would come in after a game and be like, it's just sore. So you're touching that. Mate, like, what are we gonna do with this? Like, it's sore. And if you have like in the Doha, the only way to rule it in is pain palpation. That's it. So
You can have some squeezes, which can be like little link with Lagos and stuff as well, in terms of sporting capacity. If you've got little 5 certain squeeze tests. So there's 1 or 2 is use the capacity to play, then Lagos is usually negatively correlated, so it's a higher Hagel score, the 1 or 2 VAS score. Once you're over 4 or 5 and above, people should be playing. The problem is you got 35, which they're like way where you've got to put it further.
but also if there's a bone reaction, you want 0. So
But we'll not feel it because again, it depends on whether that's coming for real. Is there a bone response on MRI? Is that the clinical pathology? Because as I said, most of them got it. So whether it's symptomatic or whether it's just I think the really interesting thing that you mentioned again, I think it's probably something for me that's a big take home with this is that if you have that, I think too often we see them, we try and we run it those stress and try and push through, we're trying to rehab them through. Trying to go back to those. You're a 17-year-old kid. It's probably got fuse racks closed. We're loading up adapters, we're doing all this stuff. You've got to settle shit down before you go shit up. You've got to settle in there. And as you said, you didn't do anything when you're stronger and better. Because you've got that pain inhibition, you can't work through these guys. You work on other things. You probably work on single leg stability, like word stability, other things. But the priority is to settle that bone stress. Then to provide a platform for you to build up strength and build up capacity. You go into that first part well, you're chasing months. So present point for everybody. He said first 2 weeks to settle down. By week 4 he was settling his hand off.
I'd say by
And
week
he
four.
did a bucket load of rehab. You allowed him an opportunity to settle down. He's not allowed your rehab to be more successful. Had you done, I'd like to squeeze this on an unfused hypothesis, a young folks and a acute sort of bone stress. You're going to make them sore. He's going to say, I'm doing this rehab, I'm working hard, I'm just getting worse. So prioritize, and that's where the bone stress is relevant, because in that case, you have to respect that before you respect any of that problem. You do stuff, there's lots of stuff you do. You have to respect the main authority before you can move on.
Yeah, I was pretty fortunate as part of my sports is we've got 2 lectures done by Edna King and Andres Cerner. So they do a lot of groin stuff. And there's one of the takeaways I took for that for professional sports actually went against everything I did previously. And if they had pain on groin squeeze, pretty much at all, we eliminated any sort of frontal crossing of the line or frontal plane exercises for those players, which for me, I was like, oh, if they got pain on groin squeeze, it's making them a bit stronger. Like, well, they're A-League players, like these guys are pretty strong. Like, yeah, let's settle them down. And honestly, that helped to reduce a lot of our incidents of groin stuff in last year's season in the Jets.
Hello team, great to see you all. Thanks for coming along and thanks for that was great, Lucia, thank you. Pick us upside down. This evening's case is objectives about how to take a target history, focus exam and appropriate investigations to localise the lesion and neuroaxis. I'm on the trauma term at the moment, so the recent exam case of mine. Functional profile, 58-year-old gentleman, right-hand dominant, painted by Jay. He had a previous compensable injury, so he's not currently working dependent on centre leg. Presents with bilateral hand paresthesia and weakness, right worse than left. And the purpose of the talk is to get a sense of a diagnostic approach to this. The symptom profile, his pain location. He had bilateral, volar hand, thumb and finger paresthesia and reported weakness, difficulty writing with table tasks, and said that he was dropping fine objects. Had no trauma history. He reported the onset was insidious over the last 18 months. Worse when he was holding the phone with a bent elbow and sleeping. The paresthesia woke him at night. He'd seen his GP and physiotherapist, had some non-steroidal anti-inflammatories, advised to hold his phone less and avoid the things that were hurting, had some nighttime splinting and wrist extension, and he reported no response to those things. Just checking the rest of his systems, he was well, no fevers, no weight loss malaise, nothing in the category B symptoms. He did have central neck pain, but normal bladder and bowel function, no falls or unsteadiness of the gait, and he had no dyspnea, cough or hemoptysis, and no reduction in his exercise tolerance. Past medical history. So he had a compensable neck and back injury in 2016. He reported a cervical spot. You don't get all the information in the exam. So he had a compensable neck and back injury in 2016. He thought he had a neck fracture, which was managed in a collar for a period of 8 weeks, and then graded reloading. Type 2 diabetes. He was 110 kilos, 6 standard drinks a day. Used THC, 15-pack a year smoker, and
Wait, have you got 20 cones a day? Heavy.
We're not working.
That's it.
yeah, this is the yeah. This is the different end of the continuum. So use. All right.
Sorry.
And he was misusing opioids, so that's a lot of morphine equivalents. 120 morphine, or 120 milligrams of morphine a day. Used insulin, Novorapid, and Ryzodeg. If anyone's using Ryzodeg, it's a little trigger that their diabetes control is poor. It's very long-acting insulin, so usually used when people forget doses. Not always, but that they're just thinking about that in the back of your head. He's on a couple of neuropathic pain medications, obviously on endone, and using diazepam, clomazepam. Getting a sense of what he thought the issue was, thought the neck was his issue, thought he had a spinal cord injury, all related to the work, no insight or no willingness to change any of his own health behaviours, and just wanted to get rid of his symptoms. Key features from the history. See? What I'm thinking, that's, oh yeah, key features from the history. When I'm thinking about this in the exam, or if I'm seeing someone, I'm thinking, what's the red flag? What's the thing that's going to really hurt someone? Something that's time dependent from a surgical perspective, something I can't miss. So, anything ring out in the history?
Brain or spinal cord. So bilateral, non-dermatomal necessarily.
Yeah, maybe.
Neurological symptoms.
Yeah, so that was my first thought as well. Bilateral hand paresthesia. I'm thinking cord level. Yeah, so maybe cervical myelopathy, has central neck pain. That was my first thought. That is concerning. A lot of other plausible differentials that come along, but the red flag that I thought that I needed to identify was cervical myelopathy. Obviously, he's got a high risk psychosocial, a lot of drivers outside the biological and acute nociception that are driving his pain. We will need to deal with those. That might not be our primary issue. So what must we rule out? Cervical myelopathy, most likely diagnosis.
Alcohol related neuropathy.
Yeah, I thought peripheral neuropathy of a diabetic and alcoholism, both of those, they're the two most common causes of peripheral neuropathy in a glove and stocking distribution. So that's plausible. I didn't ask him about his feet, but I did check that in the exam, so we get that information shortly. It's also plausible that he has a bilateral peripheral neuropathy, cubital tunnel syndrome, carpal tunnel syndrome, plausibly the lesion in his plexus from that initial injury that's missed. It's unlikely. Thoracic outlet syndrome, also unlikely, but plausible. He's a smoker, poor health literacy. Sometimes people get tumours in the apexes of their lungs, all very rare things. So this was my feeling, bilateral distribution of symptoms, worse on the right, aggravated by elbow movement. That's why I was thinking compressive neuropathy, the peripheral neuropathy, secondaries, diabetes and alcohol misuse. And I think we covered all the relative differentials. Yeah, it's an apical lung cancer, just because of his smoking history, but he didn't have any of those symptoms on history. Yeah, Penco's tumour is a classic cause of compression of the lower trunk of the brachial plexus. That presents with a lower trunk plexopathy, and is a differential for C8T1 radiculopathy, compression of the lower trunk of the plexus, or an ulnar nerve lesion. All right, what is the picture showing?
That's nice.
Oh yeah, bilateral first dorsal interosseous wasting. Yeah, good.
That's
showing
you.
Yeah, so so the first dorsal interosseous is a terminal motor branch of the ulnar nerve. So potentially localizing a lesion there. He had full movement in the upper limbs. It wasn't painful. He had tenderness over the ulnar nerve and the cubital tunnel. This is a neurological exam. He had altered sensation in the median nerve with a normal function in the muscles that are innervated by the recurrent branch of the median nerve. His anterior interosseous nerve was functioning fine. His ulnar nerve, he had altered sensation in the dorsal and volar aspect of the little finger, which is important because it starts to help localize where that lesion is in the ulnar nerve. The ulnar nerve has a branch that provides sensation to the dorsal aspect of the hand. It comes up 5 centimeters above the wrist. And so the lesion is above that level if the dorsal hand sensation is altered. And he had weakness in his first dorsal interosseous with abduction of the metacarpophalangeal joints, and also had weakness in flexion of the little finger DIPJ, which also helps localize the lesion to the elbow or above, because the motor branches to the flexor profundus to the little finger come off at the elbow. And so you have to have a lesion at that level for those to be lost. Interestingly, had normal FDP function to the index finger and middle finger. They're not innervated by the ulnar nerve. So remember, the ulnar nerve only innervates 1.5 muscles in the forearm, the FCU and the two tendons, the little finger and ring finger of the FDP. So one way to differentiate between an ulnar nerve neuropathy and a CAT1 radiculopathy is to do that. So if they're weak in these two fingers, but normal strength in these two fingers, then it's the leader's distal, the cervical spine. So now we're starting to get a picture based on the provocation and integrity testing that this might be an ulnar nerve issue. The radial nerve function was normal, normal sensation and normal strength in the sensor indices, normal peripheral nervous system reflexes, so evidence against the upper motor neuron lesion, and CNS reflexes are also normal, evidence against cervical myelopathy. Vascular exam, you have conformed hand and a normal pulse. Check areas, so always check when above, below. In the upper limb, check the spine. In the upper limb, check the C-spine. In the lower limb, check the whole spine. So you did have neck tenderness and cervical myelopathy was an issue, but a neurology didn't localize. He did have a pretty stiff sore neck with a positive Sperling's test that reproduced right-sided arm pain. So can't exclude the neck as a contributing factor at this stage. And he did have bilateral stocking paresthesia. So probably has an element of peripheral neuropathy in the context of diabetes and alcoholism.
Couldn't that be close by, isn't it?
Not in a glove and stocking distribution, unlikely. Plausible, but I don't think the distribution would be supported. Yeah, if you had a lesion that high in the cervical spine, most likely fall into a pathogen. It depends what truck is affected, but it would unlikely to lose light touch in a glove and stocking distribution. Good question. So key features from the examination. So rationalising the differential list, I thought that the interossei wasting, the tenderness over the ulnar nerve, and positive Tinel's over the cubital tunnel localised potential lesion with the remainder of the neurological findings. He did have a sore neck, positive Sperling's with reproduction of arm pain, so we can't exclude the neck. And I think he has features of peripheral neuropathy contributing to his sensory dysesthesias. What investigations would you like? Yeah, sorry to be out, mate. I thought he played a little bit of that. I like that drive.
We were cheering for you when you were on the field, did you?
No, I didn't.
You like that? Yeah, that was awesome.
Sorry, it's just segue.
Sorry for your loss also.
Maybe that's unfair to pick up. What investigations would you like to order as a team? Blood tests, imaging tests, any blood tests you'd like?
C-spine MRI.
C-spine MRI, okay, great. We got that.
Nerve conduction statement.
Okay, why did we get an MRI test?
Well, if you
Isn't
still
it just going to show incidental age-related findings in someone who has biopsychosocial drivers, and then they're going to get?
rule out the myelopathy.
Okay, still think we need to do that?
Sure.
Why?
Well, peripheral reflexes were okay, but there's still some positive C-spine findings.
Neck pain and positive Sperling which radiates distal to the acromion. Yeah, he does have frank bilateral wasting in his hand, weakness in his hands. So that's profound weakness and neurology. So yeah, I think you can break that argument.
It's progressively worse too, like you don't want to wait longer and miss it.
Yeah. Possible
Now
previous trauma. Yeah. Also, we've got an MRI C-spine. Anything else?
I don't know anything about bloods, but I assume run a whole.
Oh, you said you want nerve conduction studies.
nerve
Yeah.
conduction.
What do you want those for?
To see if you can localize stuff more.
Yeah.
With the arm side.
And we need to tighten that question up. If you're going to order something, we need to tighten that question up. Yeah.
Find where on the neuroaxis the signal stops getting through.
Yeah, I think that's good. Is there a compressive neuropathy in the upper limb which would show low conduction or reduced motor potentials in the muscles that are innervated by those peripheral nerves? That's plausible. We did that, but that didn't work. I'll tell you another reason. Cool. I think that was good. And we got an elbow x-ray and he had a chest x-ray as well, which was presented. A chest x-ray, I think, was to exclude a pancreas tumour. He got a set of blood tests and HbA1c, which is a measure of your sugar control over the previous 3 months. We wouldn't manage the whole patient, so he's going to need some help with that. The serology was normal. And a plain film x-ray. The compressive neuropathy of the ulnar nerve isn't usually associated with osseous lesions, but it plausibly has heterotropic ossification from a previous injury or an osteophyte causing compression. So plain field X-ray looks okay. Sometimes you can get alignment issues if the elbow's in valgus. That can cause a bit of stretch on the ulnar nerve, but you would see that in the clinical exam. You had this chest X-ray, which shows bilateral lung markings towards the apices with no lesion. Incidentally, you look for additional ribs in the context of thoracic outline, although that's not their story. And this MR, this fluid weighted images, sagittal and axial scans, which show, I think, incidental findings of posterior disc protrusion C6, 7, 8, but no intervertebral stenosis and no effacement of the CSF or cord signal changes. He did have nerve conduction studies, which just showed delayed amplitude and conduction throughout all the nerve with no localizing lesion. And in retrospect, that probably is because of his peripheral neuropathy. Diagnosis. Oh, no. Oh, that's good, but well outside my something I'd feel comfortable talking about. That's why I chuckled. Sorry, I wouldn't feel comfortable talking about it. Why did you think that?
First possibly for CI.
Yeah.
One of the signs.
Oh yeah.
The same with the glove and sock thing. That's the glove and sock is
And
in
we
it.
see, yeah.
Yeah, and I think this is not something I don't know much about, but temporal lesions in space and time. So it would need to be usually characteristic of I have a neurological issue that goes through some point of resolution, and then at a later time I have a separate neurological lesion with a different distribution without a specific tumour, trauma, infection, infarction causing that cause. Help me out there.
Oh, you can handle well.
Like,
You know, get going there.
you know, for the bone. No.
No, I mean, I think it is a valid question. It probably, I didn't contemplate that as a differential, maybe because of the demographics of the patient. I felt the pretest probability for MS in this person was low, and the physical examination findings were consistent with what I felt was a peripheral nerve lesion that was occurring bilaterally, right, worse than left. You had historical features of that, you had examination findings of that. The integrity of the nerve was affected on the neurological examination, but more importantly, I could provoke his symptoms. I think the examination is important. I could touch the nerve and it was sore. I could tap on the nerve, it was sore, and he bent his elbow and it was sore, or reproduce his paresthesia. So that shifted my mindset to think that the compressive neuropathy of the ulnar nerve, the elbow, was the etiology of symptoms rather than a more systemic condition. But yeah, if he had different lesions at different times, then that would probably shift my thinking. And then he obviously has, this is multifactorial, it's not just this issue going on. This guy's going to be difficult to treat. It's going to be difficult to get him back to work and independent. So treatment, bilateral cubital tunnel release in 30 days because he had such marked wasting and dysfunction in his hands. Referral to the physiotherapy team, neurodynamic exercises and graded reloading. Referral to the endocrine team for optimization of his diabetes and the unintegrated pain service to rationalize his analgesia. Like that's a dangerous amount of opioid therapy and really going to affect his outcome. It's going to be tricky. Referral to not for me. Yeah, it's crazy what people talk about, but it's amazing what I didn't appreciate it when I worked in.
I don't, you don't tunnel from just being passed out like this anyway.
I didn't appreciate this when I worked in physiotherapy private practice. You see a different demographic working in the private sector, and you don't see as much of this in private practice as a physiotherapy, but we have 114 patients, and we would have maybe 30 people dependent on drugs with this kind of history at the moment.
All these nerves get wound up by life.
Hold the line, it's a bottom of the day.
And,
Flying around.
Kick almost
straight.
Buy a new bulb.
yes, close the loop with a general practitioner, try and get it, try and nudge some change. I think that would be this. Motivational interviewing might be a challenging task. Any questions, Nancy?
You didn't speak at half the speed. What, did you time yourself?
Yeah.
Wow.
Did it all make sense? I mean, I think refining, I think it's hard to, anyone have any questions about the neurological exam and understanding where the lesion is?
Can you please rewind right back to teaching us about the fingers and which bits go where and where the nerve lesion is, please?
Oh, yeah. So I think there's a few take homes. This,
Slow down.
I won't do,
Like half
two
speed.
minutes, not this, this is when compressive neuropathies don't localize well. So often if you thought the ulnar nerve innervates the ulnar 1.5 fingers on the volar and dorsal aspect. But there's lots of ways that the nerves talk to each other called anastomosis in the forearm. So often you have compression of one nerve and they'll have neurology in the other fingers outside that 1.5 fingers innervated by the ulnar nerve. So I find it very difficult to localize compressive neuropathies based on the patient's self-reporting of the symptom. Would you agree? Yes.
I also think there's a study on that. I think there's a study on that. It's like 80% of patients report symptoms in the back of their hand when they have median nerve compression or something. So like the anatomical
Do you remember
points
the
way.
full names of the anastomosis?
Absolutely.
Okay. You don't need to. So that's important to acknowledge that if someone's symptoms are not localizing, that does, you can't exclude or rule in a diagnosis of that. Then he was talking on the phone and his symptoms got worse. So elbow flexion causing a mechanical stretch on the ulnar nerve led me to think about the ulnar nerve as the etiology. If that was spine motion, then that might localize there. But elbow, bending his elbow was the issue, and often waiting with paresthesia is classic of compressive neuropathies of the nerves of the upper limb. And then if you've got a lesion in the ulnar nerve, then it can be compressed here at Guillen's canal, it can be compressed here at the cubital tunnel, it can be compressed in the plexus, comes off the medial cord, be compressed at the clavicle. So that would be a lower trunk lesion or thoracic outlet syndrome, or it could be a C8T1 lesion. And then the way that you differentiate that, if the lesion is at the wrist, then you lose volar sensation and you lose strength in the first dorsal interossei. If it's at the elbow, you also lose sensation in the back of the hand. The dorsal sensory branch of the ulnar nerve comes off 5 centimeters proximal to the wrist crease. So then that's gone. And then you also lose the ulnar nerve innervated muscles of the forearm. And the easiest one to test is a flexor digitorum profundus, which innervates the 2 ulnar base tendons. So little finger DIPJ flexion would be evidence to support the lesion is at the elbow. The plexus is a bit of a different story. You have to have a plausible mechanism and then fit in with the other nerves that come off that cord. So the upper nerves come off the medial cord, sensory nerves is the forearm, median nerve, branch, and a nerve to the pec. So then it has to fit with that mechanism. And usually if it's the lower trunk of the brachial plexus, it'll be a sort of tractioning, like someone grabbed onto something or they fell over in that direction. And then if it's a C8T1 radiculopathy, C8 does all of this. So if they can do this, then it reassures you that the motor function C, if someone has weakness, profound weakness, and then they're strong here, maybe not coming from their spinal nerve level. And then he had bilateral symptoms. So if someone has bilateral symptoms in a non-dermatomal distribution, you have to think about the cord, but he didn't have any of the other cord features when we talked through history, and he had no upper motor neuron signs on the examination. And then we still screened it, as you said. He was well and truly embedded. Well, this is an exam case, but he was thinking that that was the cause, and then you got an MRI.
How does the peripheral neuropathy complicate your exam though when there's overlapping conditions?
Well, he didn't have dorsal sensory loss. Well, he didn't report that. So he didn't have a true glove peripheral neuropathy distribution of these sensory changes.
And his nerve conduction was just shut.
The nerve conduction wasn't helpful. I think if you didn't have provocation signs at the elbow, then you would be hard pressed to make a diagnosis of cubital tunnel syndrome. But if you touch the area that saw and the elbow and Tenel's that reproduce their symptoms.
If you didn't have peripheral neuropathy from other conditions and just had isolated cubital tunnel syndrome bilaterally, would the nerve conduction have been more definitive?
But I wouldn't use that test if the person didn't have a more, if someone came in with golden and dorsal hand symptoms with first dorsal interosseous eye wasting and a positive Tenel's over their cubital tunnel, you wouldn't organise nerve conduction. It's a clinical diagnosis.
When you say positive to nerve drop, like you go to the other side and it's fine.
Or reproduces these symptoms. Yeah.
Was like, what would that, did that get in the head of what was like, oh, like, with the right side and then test the other side, so it's the same. There's like sometimes that, I guess, my normal rules is more out, it's like, oh, it's the same.
Yeah, I think that's good. The other limb is the comparator. The other comparator you have is the subjective symptom of the person. So you find with any problem, like I think about the nerves, testing their integrity, motor, sensation, reflexes, and then their provocation. And that's all related to their experience of their symptoms.
Something you didn't do, which is very unphysio. Physio could have done it, would be a neurodynamic exam. Why didn't you do that? That was our honours program. Would that have been positive?
If I did a neurodynamic test in an orthopedic exam, they would not know what I was doing. Well, thanks for having me, Seth.
How did the wheel go? Two things. One is feedback for this evening. So it'll talk about things you enjoyed or feedback about the participations in the food and the space and things to keep making these evenings better. And then if anyone would like to register for the event this evening, you also can do that. But otherwise check your emails and that will have registration links and whatnot in it for that event and for Andy's workshop if you'd like to register with that as well. Okay. 5 minutes.